Welcome, dear chair, dear audience. Let me present my PhD research titled Novel Approaches in the Improving Quality of Life in Women who are pregnant or in the postpartum period. I'm Lőrinc Frivaldszky. I'm a resident in the Better Children's Hospital. My supervisor is Márton Keszthelyi, and with our team we are planning to improve the quality of life for women during the postpartum period and in pregnancy by finding solutions that can prevent complications in these periods. We have two projects, the first one and the second one. These are both meta-analyses, and I'm going to present the first one in a bit more detailed way. The first one is titled Investigating the Efficacy and Safety of Esketamine on Postpartum Depression Prevention in Women Undergoing Cesarean Section. So, this condition, PPD, it's prevalent, affects almost 14% of women during childbirth, after childbirth. It is treatable, but its features include a wide range of clinical signs, including sadness, sleep disturbances, and even suicidal behavior. And women who are undergoing cesarean section are especially at risk for this disease. And currently there is no preventive treatment known that has an evidence-based efficacy and safety data. And for example, a drug called esketamine, that is a version of the known drug ketamine, has a positive effect on depression, on clinical depression, and it is also used after operations and has a well-known effect to decrease depression that is after surgical operations. And we aim to assess the efficacy and safety of this drug for PPD prevention in the population of women who are undergoing cesarean section. So we are asking, does this drug reduce the risk of postpartum depression in our population? And we plan to compare this drug to the standard of care, and we plan to use it, or the articles that we are including are using it as a one-time intervention before or during the cesarean section. And we plan to measure the risk for postpartum depression and some scale scores that assess the efficacy of this drug, and also the adverse effects to assess the safety of this intervention. We use the following search key with two domains. The first one is about the drug used. The second one is about the population we are researching. We found 17 eligible full texts after the selection process, and I plan to show you 3 plots that cover the results of our research. The first one is the odds ratio for postpartum depression measured within 3 and 7 days postpartum. We are using this measurement to show how effective is drug to reduce the chance of postpartum depression. We have more than 2,000 patients included in this plot, and we found that overall, including 3 subgroups about the intervention method, we found that overall the odds ratio is 0.43. It means that almost 60% decrease in the chance of postpartum depression was measured among women who received this intervention compared to those who received placebo. This difference is statistically significant as well, and a similar effect was visible in our secondary outcome, that is the EPDS score, the Edinburgh Postpartum Depression score, that is used to measure the severity of postpartum depression. This is a score between 0 and 30, and 0 means like no depression at all, and 30 means the most severe one you can imagine. And we found that overall a 1.32 point decrease was found in women who received this intervention compared to those who didn't. This decrease is not that, I don't know, good looking as the previous result, but it is still statistically significant. Our third plot shows the adverse effects that could be measured after this intervention. Only two adverse effects were found in a statistically significantly higher rate in the intervention group. These were dizziness and hallucinations, but luckily the absolute rates of these adverse effects were 16% and 5%, that can be considered low. So overall, the strengths of our study are that we used RCTs, thus resulting in low risk of bias, but our limitations are that overall we found low number of cases. There were different definitions about postpartum depression among the studies, different cutoffs for the EPDS scale, and there were low diversity as all these studies were from China. And Zihan helped a lot with translating the articles. So we can conclude that this intervention can effectively and safely prevent PPD in this population. However, we have to monitor for adverse effects because some can occur in a higher rate in the intervention group. So we can use this intervention to prevent PPD, but we need more study these larger populations with diverse populations from different countries and different dosages and methods for administration. And of course, we have to research the prevention methods, not only for cesarean section, but for natural delivery methods as well. This paper was published this March in the Journal of Psychiatric Research. That's a Q1 journal. And let's proceed to the second project. We are investigating the efficacy and safety of different interventions for nausea and vomiting in pregnancy. This condition affects up to 80% of women who are pregnant, especially in the first 2 trimesters. And this condition is, most of the times it's mild, but it can result in some severe cases in poor maternal and fetal outcomes, malnutrition, depression, IUGR, pregnancy termination, and so on. There are lots of interventions that the clinicians and the pregnant mothers use to treat or to alleviate the symptoms of this condition, but the efficacy and safety data are very, very sparse. So we aim to assess the efficacy and safety of the available interventions against NVP. Our population in this framework is the pregnant women who are having this condition, and we are comparing the different interventions to each other, assessing the efficacy with different scores, the puke score, the visual analog scale scores, and the number of vomiting episodes, and of course assessing, it's a very, very I don't know, clever abbreviation for the score, and the safety outcomes, the adverse effect rates. And we hope to find the most effective and the safest intervention, thus to contribute to guidelines about this condition. We used the systematic search key with 3 domains, and we ended up with over 100 eligible full texts. We haven't finished the whole analysis yet. We have some plots, but we plan to present them when all the plots are available, so we can compare the different follow-up dates and different effects of the different interventions. And the manuscript writing is on the way. And if we receive the final plots, the stat team just emailed us this morning that they will finish them really soon. So we hope to submit this paper in July to our target journal. So to summarize the projects, we have 2 of them. The first one is already published. The second one is close to being submitted. And I would like to show a bit of my activities that were done during these 2 years, especially the second year. I, as an SMS, helped 10 students, and I'm helping 10 students at this time as well to progress in the research projects. I have 10 students with 19 projects, and one of them already submitted his article, and I'm very proud of their work and compassion. Thank you for your attention with a quote that is, "A cheerful heart is good medicine, but a crushed spirit dries up the bones." Thank you very much.
Thank you for the presentation and for being my SMS. I have a question about your first project. So you said giving esketamine perioperatively. So
Yes.
these projects only focus on cesarean section deliveries, not the natural deliveries?
Yeah, so we focused on only cesarean sections because this population is highly, I mean, it has a higher risk for postpartum depression, and from a practical point of view, the esketamine administration is easier in cesarean sections compared
I
to.
have one more question. So we talk about safety. But
Yes.
is it both the baby's safety and the mother's safety? And also, I'm just curious. I don't know. I'm just asking out of curiosity. But do you think there would be a difference giving the medication like right during the surgery, like cesarean section, or even before? Like, because when you give it during the surgery with IV, from IV or anything, it would also go to the baby's blood. But if you give it after taking the baby out and after the cord
Clamping.
the baby can get it only via breastfeeding. So what do you think the differences might be? Did you?
I mean, you answered your own question basically because in these articles it is given after the umbilical cord is clamped, so it is not going intravenously into the newborn baby. During breastfeeding, it can go through. It can be fed to the baby basically, but this medication is considered safe. Based on the available data in the literature, it's a safe medication during breastfeeding. And in these cases, it's a one-time intervention. The overall dose that goes into the breast milk, it's pretty low.
I have a question for your first project as well. So for the control and the other group, the intervention group, was it controlled that the pregnant patients used any additional drugs? So for example, alpha-methyl-dopa or any other drugs in the same percentage in both groups?
Thank you for the question. So the women who were in the placebo or standard of care group could receive painkillers, for example, on demand after the surgery. But these RCTs were really high quality and they really controlled for that. The only difference between the groups was the esketamine administration or not. So basically, this was all the difference, luckily.
Just a few questions. One first is, do you know the difference of the incidence between the C-section and the natural birth? I mean, the incidence of a depression.
I do not know the exact incidence rates, but as I remember, there was a almost 50% higher risk for developing PPD in women who underwent cesarean section.
And it was written that there is no prevention of the depression. Is it really true, or
no? It is. It was a bit an imprecise sentence. Thank you for the comment, because there are preventions, but there are no pharmacological preventions. So there are psychotherapeutical prevention methods for PPD, but on the pharmacological side, there is a gap in the knowledge.
Thank you. Then do not use "there is no intervention." Please change it. Because, for example, early bonding, golden hour, early breastfeeding are both preventive. Whether this is not a drug, it's not supported or not financed by an industry, then this is an intervention. So I would change, because non-ethical is no ethical, to use the term "there is no hope, only esketamine." The final conclusion would this. And our efforts must be more for our patients. And if this is not a simple drug, but mother milk or training or communication with the parents, reorganizing our units, we should do this. so interesting that all the studies included. So this is not your fault. Okay, this is a message for everybody. All the studies, or 6 or 7, was a very, very narrow time frame between 2022 and 3.
Yeah.
So, what portion of these studies was industrial studies?
Thank you for the question. I will just relate the first part of your comment. So we emphasize this in the discussion. I didn't have the time to emphasize this in my presentation. As prevention is a complex, it's a complex approach that esketamine is only just one segment of this whole picture, and our study is intrinsically narrow on this question. But this is a complex question that is a complex answer, and multiple methods and the combination of these methods should be implemented. And I do not know how many of these articles were industrial, but it is important to have at least one possibility for the pharmacological side of this complex answer for the PPD.
Okay, so this is so interesting. This peak of studies in a very narrow time, and also probably it would be it would increase the quality of your work to a little bit, not too much simplify. So a little bit specify that in the treatment or in the prevention. So to sign very early on. So this esketamine is a preventive treatment or so a prevention or a treatment? But
it's a prevention.
It's
so
prevention.
so
Okay.
PPD has not developed yet in those.
Yeah. Okay.
Yeah.
It is so interesting. Otherwise, in some cases or in some studies, just to check the raw number, 1/3 of the patients suffered. For example, the patient sizes 150 and 50 suffered postpartum depression. So 1/3 of the patients. So this is pretty high, probably. And so very fascinating your topic, and your quality of your work is okay. So sorry for this.
No, it's okay. It's just...
But this is a discussion, and we raise concern and suspicions, and so research is not just the morally elevated people's play. Okay, thank you.
Thank you.
I'd like to applaud you because you're a pediatrician, right?
Yes.
And you cover kind of a bit of an obstetrics topic.
Yeah.
And investigate a drug that is used by psychiatrists. And,
Yes. It's like a triple border, like Slovakia, Austria, Hungary. I'm standing right there.
Well done. Absolutely. A great job. There was raised an important point. Because the rate of postpartum depression changes over time.
Yes.
It's very important when you assess it, whether you assess it in this very short period, 3 to 7 days after delivery or later on. Could you maybe elaborate on that and kind of on the natural course of postpartum depression?
Yes, thank you for the comment. So you are right. It is an overall decreasing incidence as the weeks and the months pass by after the delivery. It is like a wave, similar to a wave, the incidence over time. Because of this, most of the articles used further follow-up times. I couldn't present the plot. I have very interesting plots for the 1 month follow-up after delivery. And it shows that there is a fading effect of esketamine. On one side, because this condition is also fading, and on the other side, because this is a one-time intervention, that and the effect of it just vanishes over time. But on the research implication part, it will be very interesting to see longer follow-ups, even longer follow-ups, not just 1 month, or in the longest follow-ups were 6 months, but maybe even longer. So we can see the effects not just on the PPD rates, but on the mother, on the newborn, on the infant. So it's a very interesting topic, but we need more data on that.
And maybe a bit more of a statistical question and interpretation question. The reduction in postpartum depression, day 3 to 7, I wrote down the odds ratio was 0.43, so quite substantial.
Yeah.
And you had a confidence interval 0.31 to 0.56. Would you consider that a very kind of precise effect, or give that a lot of range for interpretation? And given this information, would you kind of recommend to use it in clinical practice, or would you have exactly this one?
This one, so you mean the overall random effects model, they pulled one?
Exactly.
Yeah. So I mean, statistically speaking, this is a significant difference between the intervention and the comparison group. And clinically speaking, I think that if we achieve, like, if we can halve the chance to develop PPD, I think it's pretty relevant as well. So of course we have to assess this in a complex picture, but I think based on this plot, based on these numbers, I think it can be recommended to use for this goal.
So just another question. So what would you suggest in the clinic? So if there is a patient, you have to do a cesarean section, you automatically give the esketamine. Or just if you had some, if she had before some mental illness or something like this, or just give everybody.
Yes, thank you. It's a very, very important question. We also discussed this in our discussion. So I would go back a few steps earlier and to screen, like have an extensive screening for postpartum depression, and this way we can identify those patients who are at higher risk for postpartum depression. And I mean, I'm not. Yes, there is this EPDS, this Edinburgh postpartum depression scale that is used in practice to assess the severity of the or developed PPD. This can be used for screening as well before giving birth. So the bottom line is that we have to. I'm not a gynecologist, but I wouldn't give this drug to everybody, like without screening, like without thinking about the risk stratification and such. So I would screen extensively and identify those groups who are at higher risk for PPD. And in this case, in these patients, I would consider giving it during the cesarean section.
Just
yeah.
I'm just because I'm curious about it.
Yeah.
Because I'm a gynecologist.
Yeah.
So, and if you give this medicine as a prevention, how long you have to give this medicine after the birth?
In this study, it's a one-time intervention. It was either an infusion after clamping the...
One infusion.
Yeah, or it was in the other cases that it's like the single dose, as you can see on the plot. And there is a PCI. It is the patient-controlled analgesia when it is most of the time a 48 hours long infusion, and the patient can give boluses to themselves. So not infinitely, but with some time lockouts. But this is it's a one-time intervention, so it is after the delivery, one time, or in the first 48 hours.
Thanks.
The efficacy is varying between the four studies a little bit. In the combined approach and in the single dose as well. Did you observe any differences between the study from the strategy, so from the timing or from the route of application?
Yes, thank you. It's a limitation that there were really different dosages and administration. I mean, the dosages were different. There were some similarities, but there is a need for more studies to identify that administration and that dosage that is the best for this. So this is where one of the reasons that heterogeneity comes from.
Can you go to your second plot?
Second plot, yes.
What's the effect size on this, and why did you choose that?
This is a mean difference. So we measured the difference between the mean EPDS scale in the intervention group and the mean EPDS scale in the control group. So this is the effect size in this case.
Right. So this is when was this administered, this EPDS, for these outcomes?
For these outcomes, it was between 3 to 7 days. It differed between the different studies, but it was during the first week, if we are speaking generally.